A very good morning to all. I am Dr. Ankit Gangwar, working as a reader in the Department of Oral Maxillofacial Surgery at Babu Banarsi Das College of Dental Sciences, BBD University, Lucknow. Topic for today's lecture is oral submucous fibrosis. Definition of oral submucous fibrosis: an chronic insidious disease affecting any part of the oral cavity and sometimes pharynx, although occasionally preceded by or an association with vesicle formation. It is always associated with juxtaepithelial inflammatory reaction followed by fibroelastic changes in lamina propria with epithelial atrophy leading to the stiffness of oral mucosa, causing trismus and difficulty in eating. As you all know, it is a precancerous condition strongly associated with the use of areca nut and pan masala. Its precancerous nature was first described by Paymaster in 1956. Now come to the etiopathogenesis of oral submucous fibrosis. It's multifactorial. Local are most common is areca nut, chilies, systemic factor along with nutritional deficiency, genetic predisposition and autoimmunity. Most important is the chewing areca nut is the major etiological factor. Epidemiological and in vitro experimental studies also shows that. No. Nutritional deficiency may be secondary. Oral submucous fibrosis patient cannot tolerate spicy food and the opening of the mouth of oral submucous fibrosis patient becomes smaller, which may affect the normal food intake and lead to nutritional deficiency. Areca nut contain 4 alkaloids: ericoline, ericadine, guavacoline, guavacin, and ericoline main agent. Flavonoids, tannins, and catechins, fibroblastic proliferation, and increased collagen formation. Now, chronic placement of betel quid, that is areca nut, leading to the release of ericoline and leading to the fibrosis. That will lead to the rigidity and limitation of mouth opening. Now come to the role of the ericoline. Ericoline, when mixed with the slaked line, hydrolysis occur leading to the release of ericadine, which will stimulate the fibroblast stimulation that increase the collagen synthesis. Now, stabilization of that formed collagen by tannins and catechins. Large quantity of tannin present in the areca nut inhibit collagenase and reduce collagen degradation. Because of this, ericoline plus tannin decrease degradation of collagen and increase production of collagen. Now, ericoline increase generation of ROS, leading to the activation of various transcript factors, which will lead to the stimulation of CTGF, fibroblast and endothelial cells, fibroblastic proliferation and increased collagen formation. Now, ericoline leading to the inhibit activity of collagenase that will increase the production of collagen and decrease degradation of collagen. Now, presence of copper in the nut, copper containing in areca nut, increase activity of lysis oxidase enzyme leading to the fibroblastic stimulation and proliferation that will also lead to increased collagen synthesis. Now, clinical feature of early oral submucous fibrosis and advanced oral submucous fibrosis. In early oral mucous fibrosis, the patient feels burning sensation along with a blister formation, ulceration present, excessive salivation along with defective gustatory sensation, and a dryness of the mouth. In an advanced oral submucous fibrosis patient, that is blanching of the oral mucosa, slightly opaque, white fibrous band that is vertically palpable, fixation, shortening or deviation of the uvula, impairment of the tongue movement, inability to blow or whistle, difficulty in swallowing, along with nasal voice. As you can see in the first picture, blanching seen over the left buccal mucosa, blanching seen even on the ventral tongue in the second diagram, and the floor of the mouth leading to the restricted tongue mobility. These are the clinical features. Decrease in mouth opening in the patient of oral submucous fibrosis. Soft palate, fossipillar showing redness, shortening of uvula. See shrunken uvula as you can see in the first picture. Malignant potential. The precancerous nature of oral submucous fibrosis was first discovered by Paymaster in 1956 when he observed slow-growing squamous cell carcinoma in one-third of the patient with suffering from oral submucous fibrosis. This was confirmed with various groups, and Prinvog in 1972 put forward 5 criteria to prove that the disease is precancerous. They include high occurrence of oral submucous fibrosis in oral cancer patient, high incidence of squamous cell carcinoma in patient with oral submucous fibrosis, histological diagnosis of cancer without any clinical suspicion in oral submucous fibrosis, high frequency of epithelial dysplasia, higher prevalence of leukoplakia among oral submucous fibrosis. Malignant transformation rate along of the oral submucous fibrosis is 7 to 13% according to 2006 study. Tilakratne study. According to long-term follow-up study, a transformation rate of 7.6% over a period of 17 years was reported by Murthy in 1985. Now, biological study, blood chemistry and hematological variation. The patient suffering from oral submucous fibrosis leading to the decrease in iron, vitamin B12 and folate level, while increase in ESR, anemia, eosinophil, gamma globulins. Come to the classification of oral submucous fibrosis. Various classification are given. Classification based on clinical features, classification based on histopathological feature, classification system which based on both clinical and histopathological feature. Prinvog in 1989, stage 1, that is stomatitis, include erythematous mucosa, vesicle formation, while stage 2, fibrosis occurring in healing vesicle, ulceration, which is the hallmark of this stage. Early lesion demonstrate blanching of oral mucosa. While stage 3, that is sequelae of oral submucous fibrosis, leukoplakia in more than 25% of the patient, speech and hearing deficit may occur. 1995 LIDR classification based on the interincisal distance divided into 4 groups. Group A, mouth opening greater than 35 cm, while in group B, the mouth opening is 30 to 35 cm. In group C, mouth opening is between 20 to 30 millimeter. Group D, mouth opening less than 20 millimeter. Interincisal, all are in millimeters. Now, Ranganath et al. 2001, based on the mouth opening parameter of normal patient. Group 1, only symptoms with no demonstrable restriction of mouth opening. Group 2, limited mouth opening 20 mm and above. Group 4, mouth opening less than 20 mm. Group 4, advanced oral submucous fibrosis with limited mouth opening, precancerous or cancerous changes seen throughout the oral mucosa. Now, classification based on histopathological features. The most accepted classification based on clinical and histopathological feature. Khanna and Andrade classification, 1995. Group 1, very early case. Feature is common symptom is burning sensation in the mouth, acute ulceration, recurrent stomatitis, not associated with mouth opening limitation. In histopathological feature, you can find fine fibrillar collagen network with marked edema, blood vessels are dilated and congested, large aggregation of plumps, young fibroblasts present with abundant cytoplasm. Inflammatory cell mainly contain polymorphonucleoside with few eosinophils. Epithelium is normal. Now group 2, that is early case. Buccal mucosa appear mottled and marble-like. Patient with interincisal distance of 26 to 35 millimeter. Histopathological feature of early case, that is group 2. Juxtaepithelial hydration present. Collagen present as thick but separated bundle. Blood vessel dilated and congested. Young fibroblasts seen in moderate number. Inflammatory cells mainly consist of PMN leukocytes with few eosinophils. Occasional plasma cells are also seen. Flattening or shortening of epithelium, retipex evident with varying degree of keratinization. Group 3, that is moderately advanced cases. Trismus is evident with reduced mouth opening, interincisal distances 15 to 25 degree. Buccal mucosa appear firm attached to the underlying tissue. Atrophy of vermilion border is seen in group 3 cases. Vertical fibrous band are palpable at soft palate, pterygomandibular raphe, anterior fossil pillars. In the histopathological feature of group 3 patient, juxtaepithelial hyalinization, thickened collagen bundle, blood vessels mostly constricted, matured fibroblasts with scanty cytoplasm, spindle-shaped nuclei. Inflammatory exudate consists mainly of lymphocyte and plasma cells. Epithelium marked atrophy with loss of retipex. Muscle fiber seen intercepts with thickened and dense collagen fibers. Group 4A, that is advanced stage, trismus is seen with reduced mouth opening less than 15 millimeter. The fauces is thickened, short, and firm to palpate. Uvula is shrunken, appears small, fibrous bud, look like a fibrous bud. Tongue movement are limited. On palpation of link, circular band are felt around the mouth. Now, group 4B, advanced cases with pre-malignant and malignant changes. That is hyperkeratosis, leukoplakia, or squamous cell carcinoma is seen. Collagen histopathological feature, collagen hyalinized as smooth sheet, extensive fibrosis, obliteration the mouth, mucosal blood vessel, eliminate the melanocytes, fibroblasts were markedly absent within the hyalinized zone, total loss of epithelial retipex, mild to moderate atypia present, extensive degeneration of muscle fiber is evident. Now the treatment part. Treatment is divided into two parts, conservative treatment and a surgical treatment. In a treatment, first is the conservative. Restriction of the habit. Advise the patient to stop chewing areca nut or other tobacco products. Corticosteroids are given that will suppress inflammatory response. It prevents fibrosis by decreasing fibroblastic proliferation and deposition of collagen. Local injection or an intralesional injection, topical application or a mouthwash is required. Hyaluronic acid, that will break down hyaluronic acid, lower the viscosity of the intercellular cement substance and also decrease collagen formation. Intralesional injection of hyaluronidase used in the dose of 1500 international unit. Chymotrypsin 5000 international unit. Fibrinolytic agent dissolved in 2% lignocaine. Or one more thing, placental extract. The combination of dexamethasone, hyaluronidase, and placental extract were found to give better result than with the single drug. Nutrition support, high protein diet with vitamin B complex supplements and minerals, physiotherapy, forceful mouth opening, heat therapy. If patient is failed to respond with these treatment or a very advanced cases, surgical treatment is required. Cutting of the fibrous band with reconstruction with buccal fat pad and other different type of flaps that I will cover in the later part of the lecture. Now the surgical treatment. Surgical intervention mostly required in group 3, 4A and 4B patient. In the surgical treatment, the operation is performed under general anesthesia with nasal intubation. Nasal intubation is required as the patient is not able to open the mouth. The incisions are made with the surgical knife along the side of the buccal mucosa at the level of the occlusal plane, away from the extensions orifice. Incisions is carried posteriorly to the pterygomandibular raphe or anterior fossil pillar of the fauces and anteriorly as far as corner of the mouth, depending upon the location of the fibrotic band, which restrict mouth opening. These fibrotic bands are always detectable by palpation. The wound created are further freed by manipulation until no restriction is felt. The mouth is then forcefully opened if mouth opening is acceptable, approximately 35 millimeter. If not acceptable, the coronoid process is resected if mouth opening is less than 35 millimeter. Bilateral coronoidectomy is required. As you can see in the picture, in the first and second picture, you can appreciate removal of the coronoid process, and the incision is extended from the corner of the mouth, till the retromolar triangle along the occlusal plane. What is buccal fat pad? Buccal fat pad was mentioned by Hister in 1732. It's an anatomical element and is named as glandular molar. and it was described by Vishit in 1802. Shamon in 1990 was the first to describe the anatomy of buccal fat pad. Now, buccal fat pad is divided into three lobes, that is posterior lobe, intermediate lobe, and an anterior lobe. Now, and the four extension: pterygopalatine extension, pterygoid extension, temporal extension, and the buccal extension. Buccal extension is towards the mandible. This pterygoid extension or pterygopalatine extension is towards the infratemporal fossa and towards the temporal bone. Temporal extension is towards the ear. The main body lies in the anterior border of the masseter muscle and lies deep on the posterior maxilla forward along the buccal vestibule. The parotid duct and zygomatic and buccal branch of the facial nerve cross the anterior and lateral surface of the buccal fat pad. The anterior surface of the buccal fat pad is covered by the buccal branch of the facial nerve, while the lateral border of the buccal fat pad is covered by the zygomatic branch. The buccal extension, which together with the body accounts for about half of the total weight and lies superficial within the cheek and is largely responsible for contour of the cheek. The main mass of the buccal fat pad occupies the buccal space bounded medially by the buccinator muscle and laterally by the masseter muscle and rests on the periosteum that covers the posterior buccal aspect of the maxilla. The buccal fat pad has a constant blood supply through the small branches of facial artery, intermaxillary, and superficial temporal artery. The buccal fat pad is fixed by 6 segments to the maxilla, posterior zygoma, inner and outer rim of the infraorbital fissure, temporalis tendon, and the buccinator membrane. The mean volume of buccal fat pad in males is 10.2 ml, while in female is 8.9 ml. The mean thickness is 6 mm. Now, the function of the buccal fat pad is prevent negative pressure in the newborn while sucking, enhancement of intramuscular motion, the protection of the neurovascular bundle, how to approach. The buccal fat pad is approached through 1 centimeter long vertical incision in the reflected periosteum posterior to the zygomatic buttress. Now, a curved hemostat is introduced through the periosteal incision aimed cranially in the region of the third molar and the withdrawn wide open in such a way that a submucosal tunnel is created. This maneuver is repeated if necessary until the buccal fat pad is appear. The buccal fat pad is teased out gently from the bed with pressure on the outside of the cheek until the sufficient quantity is obtained to cover the defect without tension. No aspiration is performed in order to protect the buccal fat pad during the surgery. Complication of buccal fat pad: partial breakdown, excessive scarring, limitation in mouth opening, cheek deformity, facial nerve injury, occasional hematoma, pain lasts up to several weeks, infection. Advantages: it is quick and simple method. The incidence of failure is low. It can be used in patient under local anesthesia. It is very comfortable for the patient. Morbidity is low. It can be used in association with other flap as a second layer. Disadvantage: it can only be used once. If this surgical technique fails to resolve the defect, more aggressive treatment is required. Because of thickness, it is suitable to cover and provide no bulk. In some patients, a small depression may appear in the cheek. Now, for the reconstruction of the surgically excised area of oral submucous fibrosis, equinase nasolabial flap. It is also described by Sushruta in 700 BC in the manuscript description of the nasolabial flap. In 1864, von Langenbeck used the nasolabial flap for reconstruction of the nose. In 1944, SR described the use of inferiorly based nasolabial flap to close the palatal fistula. Facial artery is the arterial supply of the inferior base of the flap. Modification in 1981, Rose described the one-stag arterialization nasolabial island flap for the floor of the mouth reconstruction. Extended nasolabial flap, Rajiv and Borle et al. In 2008 described the extended nasolabial flap. They have taken that part from the corner of the mouth based on the facial artery, rotated and inserted inside the oral cavity to cover the defect. A small transbuccal tunnel is created near the commissure area. The pedicle is 1 centimeter lateral to the corner of the mouth, and the diameter of the pedicle is roughly 1 centimeter. Large amount of tissue and flap to be provided. Disadvantage: nasolabial flap cannot be extended adequately to cover the raw area. They also cause facial scar and often it is hair bearing. Complication: loss of nasomaxillary crease, creation of an edematous and bulky flap. Partial necrosis of the flap occur when the flap is too long related to the base. Or you can use tongue flap to cover the defect. Dorsal tongue flap, lateral tongue flap, double door tongue flap, medial transit tongue flap. Or you can use temporalis flap to cover the defect. Or you can use bipedical radial forearm flap. Or you can use collagen as a graft. It takes 5 to 10 days for adhesion. Collagen membrane to cover the mucosal defect after the excision of the band can be used. Collagen membrane is, what are the advantages? Is easily available. Application of collagen membrane or mucosa is simple. Good tolerance of the membrane by oral tissue. There is need not to perform any secondary operation or second site to harvest the graft. No morbidity. No problem is associated with the donor side. Or you can use skin graft. Split skin graft you can use, or a full thickness skin graft. This is Humbee's knife to harvest a skin graft. Or you can use laser for the resection of fibrous band. The incision is made approximately 2 mm deeper until the muscle layer is reached. Incision only the fibrous mucosa and submucosal layer. And one more incision is made inferior to the previous one, beginning from 1/3 of the foramen incision to form inverted Y. At least 5-watt laser is required. Advantages: no bleeding, less scarring, no second site surgery required, no tissue shrinkage after surgery, no wound dehiscence, less inflammation and edema. Patient who has underwent surgery for oral submucous fibrosis should be put on rice tube feeding for next day for 7 days. After the oral mucosa heal, patient are giving oral feed. All patients are instructed to stop the habit. Patients are taught mouth opening exercise with a Hester mouth opener or using an ice cream stick. To carry out this exercise 5 times a day, half an hour session. Patients are followed at an interval of 2 months, 6 months and 1 year after the surgery. Thank you.